So I'm Steve Milosavljevic. I'm a professor in the School of Rehab Science. I'm also ensconced down here, and really enjoy working down here with you guys and bumping into you from time to time. So it's our turn to offer a discussion. I want to introduce you first to Tayyab. This is Dr. Tayyab Shah. Tayyab is a geospatial researcher, geographer. Is that correct? And he's embedded in the CHASA unit, and does a lot of research relative to geospatial mapping from a geographic perspective. Should we introduce ourselves? Do you normally introduce each other? You don't? Just carry on. Okay. You can introduce yourself when you talk.
Sure.
So we decided to not just talk about one project and all the ins and outs of that project, but talk about a number of projects and the directions that we've been taking.
That's the camera remote. You have to use the arrows on the keyboard.
The directions we've been taking since 2013, and we're still producing, still publishing, and undertaking a bunch of work. We thought it might be interesting from your perspective, see how geospatial mapping certainly has contributed to my healthcare research, and Brenna hasn't arrived, has she? Some other people associated with the research team also. Okay, Tayyab. So we'll do our land acknowledgement first, and I quite like this one. The land is acknowledged our mother, the earth. The University of Saskatchewan is committed to honour and support the Indigenous peoples, Indigenous cultures, Indigenous values, and Indigenous languages that belong to the land of Treaty 6 territory and homeland of the Métis. So this is me, a clinician, researcher, getting involved in geospatial mapping. It was serendipity. I didn't plan it. It happened because I stumbled into the right people at the right time. First one. In 2004, it started. You'll see the first name on this topic is called Diggerud Online. Diggerud is a district in the Fron district on the Oslo Fjord of Norway. And his name's Thomas Fritzvold. And he married my daughter. And he was busy doing
his PhD.
Honours degree. Honours degree. And he needed a topic. And the people back, so he's old family Norwegian. And they go back many, many, many generations. And they have a patch of land in the Fron, that's called District of Norway. And the government was making some decision about putting some major highway through this district. And the people were up in arms and didn't like this. And he bumped into these other people, Anthony Moore, Albert Chong. And he knew me because I was the father of his wife. And he was having trouble writing everything he wanted to do. So I ended up joining the project. Because my daughter recommended that I did. So he wrote this project that is basically mapping that Norwegian community. And it was my first introduction to geographical information systems and mapping. And it set a few little things in mind. It was serendipity, basically. And so essentially Thomas looked at developing this GIS resource for that community that were up in arms with the government about setting a new highway through their community. So basically, next one. And essentially, on the left-hand side, you can see that's the edge of the Oslo Fjord. And this is the community with its roads, etc. And GIS mapping allows you to add a number of areas. And you can see all these different layers you can actually add. I can't add them all to that map, but you can add layers of labels and buildings and roads and properties and coastlines. You can actually add people and communities. You can do a whole bunch of different things. But in essence, that's what happened. So I helped me do that. That was my first introduction in 2004. My second introduction, so I kept doing my research. I completed my PhD in 2004. My second introduction was we got a grant to look at some of the agricultural research that we've been doing, looking at tractors, quad bikes, vibration exposure, etc. And we got something like a $200,000 grant. And I needed someone to work as a research assistant to help with the math and the analysis of all the vibration analysis we were doing. And I put an ad up there, and this gentleman called Nasser Baghiri, he had just completed his PhD, and he was looking for work. And so I took him on because he had a really great appreciation of math and analysis. And he worked a lot with us. And sometimes NASA and I would sit around and talk. And one time I asked him, I said, NASA, what did you do for your PhD? He said, geospatial analysis of healthcare delivery in the southern part of New Zealand. And actually, where were the hotspots of healthcare delivery? Where was the poor delivery of healthcare? His whole PhD was based on that. And so he started talking to me a lot about his thesis and the research he did. He came from Iran. He worked with me for 18 months. We put in a grant application and an application for some postdoctoral fellowships for him because I was very keen to work with him further. This is in 2010 and 2011. Unfortunately, we didn't get the grants, but he introduced me to understanding how geospatial analysis could be associated with healthcare delivery and analysing healthcare. So NASA, NASA, you now look at his title in 2011, 2012, he was looking for postdoctoral work. He ended up going to Australia as a postdoc, and now as a professor in geospatial epidemiology at the University of Canberra. He's moved right up to the top of the rung. And he and I still keep in contact. He's been in contact with Tayyab and myself as well. So he's doing very similar geospatial analysis. And I came here in 13, sorry. I'm setting the scene for how this all came about. In 2013, I came here, and the applications that we put in for grant money in New Zealand, which we only put one application in because then I got offered the job here. I took these project ideas with me here to Canada, and the College of Medicine was very generous with giving me a decent amount of startup funding. And one of them, I gave them a list of 6 projects I would like to get involved in, which they funded me. And one of them was geospatial evaluation of rehabilitation services in Canada, particularly focusing obviously in my profession, which is physiotherapy, but looking at a whole bunch of different ones. And so we got that funding, and then through contacts, Brenner and Scott Bell. We found out that Tayyab was just finishing his PhD in 2013 in geospatial research, and Tayyab and I met. Brenner joined the crew, and we met up, and we decided we'd use some of this funding and apply for some grants, etc. And Tayyab and I have been working on in excess of, it's about 12 or 13 different publications since 2013 relative to geospatial health matters. And about us, that's us. There's Tayyab, there's Brenner, who's part of the team, myself. We've got the 2 middle slides on the left. Is Tayyab was awarded with, we applied for, and he was awarded the top postdoctoral award from SCHERF in 2015. So he got the big prize as a #1 postdoctoral application working with us. And that was him getting his award. And since then, we've been doing a number of projects. And you can see we've got collaborative research from 2014 onwards, up to over 10 manuscripts, spatial access to healthcare services, including physiotherapists, family physicians. We published on these topics, physiotherapists, family physicians, dental services, nurse practitioners, optometrists. From the geographic context, we've looked at it provincially within the province of Saskatchewan in some of these topics. Urban in the city, this is Saskatoon. Tayyab's also done some city analysis in Ontario. The prairie provinces, we've compared Alberta, Saskatchewan, and what's the next province? Manitoba. Always struggle there. Manitoba, comparing healthcare delivery and accessibility across the 3 prairie provinces to see where differences lie. We've done it at a national level. We looked at expression of physiotherapists, where the need is across the whole country, a national level. And we've done it internationally as well. We've done physiotherapists nationally and optometrists nationally as well. We were approached by the Canadian Optometrists Association. They wanted to map where all their clinicians were. They wanted to get a feel for that. And we were approached by people in New Zealand. This lady on the middle slide on the bottom, this is Miranda Bueller. she was an undergraduate physiotherapist who I taught. And so she got very interested in the fact that we had previously tried to map physiotherapy accessibility, rehabilitation accessibility. So she approached me, and I approached Tayyab, and we got together as a group, and essentially set up some funding for her. We brought her here to Canada, and she worked in Tayyab's lab that basically analysed a huge amount of New Zealand data relative to accessibility and equity of access for healthcare in New Zealand. And currently we're working, the last slide on the right, we've got myself, we've got Tayyab, we've got Sue Ellen from the Health Quality Council, and Udoka from Family Medicine. And we're looking at different ways of interpreting Canadian and Saskatchewan data to look for comparative ways to develop what we call the deprivation index. New Zealand has a health quality deprivation index. Other countries have them as well. Canada also has one, but there are some factors are missing. So we're actually working on data that we managed to access, and we're working as a group looking at, is there a way to create a more sensitive health deprivation index in Saskatchewan?
We are trying to modify the existing deprivation index using some survey data. We just want to be adjusted it because mostly the census-based variables. So we're trying to see if we have any survey-based information from the population, so it can be adjusted those quantiles.
Cool. Right. So some of the papers, I'm not going to read all the bits and pieces out, but we've been involved with comparing geographic distribution of community-based physiotherapists and family physicians across Saskatchewan, looking at inequity of accessibility. We've looked at measuring geographic accessibility to rural and remote healthcare services. That was more a methodological paper, examining the supply and demand for physiotherapy in Saskatchewan, the relationship where physiotherapists work and the population health need. And the outcome of that is not too difficult to imagine, that where physiotherapists work is not necessarily where the greatest health need is either. And it's the same in Australia and the same in New Zealand as well. And variation, the geographic distribution of physiotherapy student clinical placements in rural Saskatchewan. And we've obviously found disparities in the analysis. And Tayyab we've been able to access census data, open access professional data, and where the students have got placements, and we publish these manuscripts. And so this is one that we did within 2 prairie provinces, determining geographic accessibility of family physician and nurse practitioner services in relation to the distribution of seniors within 2 Canadian prairie provinces. So you can see we've got Alberta's there on that bottom table, has a population of 3,600,000, and Saskatchewan 1,033,000. This is 2017, I think, was it? So,
like paper.
So it's not the very latest data about what we did. So we noticed that Alberta had 3,986 family physicians. Saskatchewan had 1,039 with a mean population practitioner to population ratio to 10,000 people, 10.8 for Alberta, 9.29 for Saskatchewan. More nurse practitioners per population in Saskatchewan than Alberta, and a combined value for family physicians and nurse practitioners higher in Alberta than Saskatchewan. So here, this is the interesting one. We need a floating catchment area gravity-based measure, and we're looking at provider access scores per 10,000 people. And so you can see the top right-hand corner, you can see that graphic. So the different colors, the dark green one, 12.6 to 25.7, means there's a high level of access score in these districts, these health regions across Alberta and Saskatchewan. 7.6 to 10.0 was about the mean, is that right?
So the health regions are overlaid with a magenta color, but actual polygons are Canadian Community Health Consolidated Census Subdivisions, which is like municipalities.
Yeah. And so we're looking at, so you can see in this case, access, the darker green score means there's higher level of accessibility for family physicians in those areas within Alberta and in Saskatchewan. The lighter colour, that means lower level of accessibility.
So in this case, if we want to see this score, usually we use like a physician to population ratio. It's a simple number of physician and divide by the population in that particular geographic region. So usually that method is more applied on large units like provincial and national levels. But when you go to the local levels, so there are so many municipalities where you have no practitioners, the communities. So it means there were too many zeros. But actually they have a proximity. So in this method, floating catchment area, we try to develop a catchment area regardless of geographic boundary. So it will give us a more flexibility to go reach out up to a certain geographic level or distance or based on the network. So that's why these all scores are, you can consider equivalent to the physician to population ratio, but they're calculated, we're using a different approach.
Right. This is where we use distance decay, yes?
Yeah.
So you can actually see it's a proximity ratio, so it's good. Okay, this is the population in these areas of Saskatchewan and Alberta where they're greater than 20.1%. You can see those dark colours with the seniors, population 65 and above. Different colours for population, less high percentages, 14.9% to 20%, 9.7 to 14.8. So the younger populations tend to be the lighter colour, where the populations have got a greater number of seniors of the darker colour.
Yeah.
So it gives us the percentage of the population age 65 and over.
Yeah. So purpose of this one is we have access, and you want to see where the healthcare need is there. So one of the need area is 65 plus population. Finally, we're going to see the mismatch between the accessibility and the availability where the higher need is, where the higher proportion. So when we will compare them, so we have this slide.
Mm-hmm. There you go. You know it.
Yes, sorry to interrupt. So what we did, we divide the accessibility into two groups, above and below a threshold value, which is we use 7.5 per 1,000 population. And in case of the senior population, we use 14.8% above and below. So we have two categories, we have four possibilities. So for example, this below and above. So this below means they have a poor accessibility, and above means they have a high percentage of the senior population, which is a mismatch of the need. So there where we need a more healthcare services actually is opposite to that. So those areas you can see in the distribution of those areas. It's kind of your crosstab, or like chi-square test. In other words, we can run those kind of things. So normally we support the chi-square to see this test, how you want to go it. So usually we initially start making more simple where we have two categories, but sometimes we need to make 3 by 3. So we use moderate, like low, medium, moderate, and high. So then we have 9 possibilities instead of the 4, depending on the situation where we're using it.
Good. So the below above one, that's what you're talking about, right?
Yeah.
Okay, cool. So here's another example of what we did, and equity of geographic accessibility to physiotherapy care in New Zealand. The Maori word for New Zealand is Aotearoa, and Aotearoa stands for the land of the long white cloud. So New Zealand's got a chain of mountains in the South Island, 800 kilometres long, very similar to the Rockies, and Maori call New Zealand Aotearoa. So we've got people here from Tayyab and myself from Saskatchewan. We've got Miranda and Meredith from New Zealand, and Mark Tennant and S.T. Kruger from the University of Western Australia. That was our team, our international team. So we published a couple of papers on this, Geographic Accessibility Physiotherapy Care at Aotearoa, New Zealand, and Spatial Equity of Physiotherapy Accessibility in Aotearoa, New Zealand, in relation to Maori and Pacific ethnicity, socioeconomic deprivation and rurality. Yeah.
So once we develop the methodology, so now we are trying to apply in a different area. So this is one of the case study that we apply that one.
In fact, Tayyab's brought up a really good point about bringing up the methodology. Essentially, the methodology is applicable to any data that you can create a geographic location for. You can identify a geocode location for a service, or a need, or healthcare, and it can be mapped. Then GIS is the place to go. That's what we'll basically be doing. Where the healthcare delivery of the population needs were, we could map that, and because we had access to geospatial information. So essentially for physiotherapy, musculoskeletal conditions, cardiovascular illnesses, neurological disorders, excessively burdened Maori and Pacific people. When we talk about Pacific peoples relative to New Zealand, we're talking primarily people from Samoa, the Cook Islands, Tonga, and Fiji, and probably a few of the other islands as well, but they migrate to New Zealand. It's poised to play a major role as part of the rehabilitation service in the country. However, accessibility of physiotherapy across New Zealand was not known, and our aim was to examine the geographic distribution of the physiotherapy workforce across New Zealand relative to Maori, Pacific, rural, and socioeconomic deprivation. So we couldn't find one singular access point to find out where all the physiotherapists were and where their geolocation was. But we used a number of resources. ACC in New Zealand stands for the Accident Compensation Corporation. Basically, they're the private funder of a lot of physiotherapy services. Te Whātau Ora is physiotherapists working in healthcare, in the hospitals. And the Ministry of Education also employ physiotherapists. So through public accessible databases, we were able to identify where 5,582 physiotherapists worked in New Zealand. And we could find geolocations for those people. That was 96% of all the people registered as physiotherapists within the Physiotherapy Registration Board. If we wanted to get the full 100%, we would have to go through very strict ethical criteria. We accessed publicly accessible databases. And essentially we used New Zealand for the population basis. We used New Zealand census population data at a mesh block level from 2018. And we used the 3-step floating catchment area calculations in order to create these maps. Okay. Map 1 was essentially go ahead. So essentially, it's a cross-sectional population-based study, dimensions of access about potential versus actual, and spatial versus aspatial. So this methodology is set up for spatial accessibility, where you can find data and map it. Aspatial doesn't fit into it wonderfully well, but it can do. There are ways to do that by doing interviews and qualitative studies with population groups as well.
Thanks.
Yeah, good. So essentially, we look at the 3-step floating catchment area. The physio data are the ones on the left. Where the X's are where would be physiotherapists had their facilities, the number of physiotherapists, and the population data on the right. Okay. And the mesh blocks, those circles are inside the centroids within the census data. Is that correct? Yeah. Okay, good. So then we looked at creating decay factors around where the physiotherapists worked and where would people go to access the physiotherapist. If you live right next door to the physiotherapist, essentially made the assumption you would probably go and visit that physiotherapist. Okay, we couldn't guarantee it, but the further you lived away from where the physiotherapy practice was, then we built in a decay factor. That there's the chances are that you might go left, right, or visit some other therapists around as well. So the decay factors here, we've got, you could say 2.5 kilometres, as we had to make assumptions. There'd be probably close to 100% chance that person would see that physiotherapist. If they lived 10 kilometres away, the chances are 70% of the population would likely be attending that physiotherapist. Same with all the way out to 50 kilometres, where we would make the assumption 30% of the population might access the physiotherapist. We have no way of proving it, but we had to set some parameters by which we could do analysis. It's the same with the physiotherapy and the decay factor on the right-hand side as well.
So basically, we try to determine the total population within the catchment area of each and every practice location, and we do use a different method. So these decay factors, slow and fast, depending on the criteria, country, healthcare professions. Every like dental have a different criteria, physio has different, family physicians. So those things will be adjusted according to the professions of those. But eventually, we apply that and calculate the aggregate score and the access level, and then we produce these maps.
Okay. And so this is looking at the distribution of physiotherapy accessibility, and you can see access scores on the table on the bottom left, and where it says 0.05 to 0.50, essentially the average physiotherapy number of physiotherapists per 10,000 population in New Zealand is 11.88 physiotherapists per 10,000 people. Okay. Interestingly, Canada's is about 6.9 to 7. So New Zealand has a high physiotherapy to population ratio. But we also looked at the number of standard deviations above and below that mean value of 11.88. And you can see that access score. So where the top of those access scores is less than greater than 2.5 standard deviations below the mean score. And the other color at the very bottom is greater than 2.5 standard deviations above the mean score. Essentially, you can see with those mauve colored areas, geographic areas in New Zealand, is where accessibility is lower. Okay?
So below average.
Below average accessibility for physiotherapy services.
So that's why we use the standard deviation classification on the accessibility score to just have idea comparatively on the two different color schemes.
And you can see those green areas up the top. You've got Auckland. You've also got Wellington, which is more white, which is about average. Mm-hmm. That's the capital city of New Zealand. You can see Christchurch. That's where my son lives. It's a city of about 360,000 people. And on the South Island, about 2/3 of the way down, you see some very dark green areas. That's very high accessibility for physiotherapy services. Why is that? 6 of New Zealand's major ski fields are there, and most of the tourists. Has anyone been to New Zealand? It is the Queenstown, but 6 of the major ski fields there. The American ski team for the Winter Olympics comes to New Zealand. New Zealand's winter to do ski training. Other countries do as well. So a lot of tourists come to that lower area. So there are something like in 20,000 people, there are something like 30 physiotherapists working in that one area. So physiotherapists tend to go where the money is, which I don't blame them for doing that, but it just shows this is a policy-like analysis to influence where should physiotherapy services be delivered. You would think healthcare delivery of services should be where the need is greatest. And obviously there is accessibility issues disproportionately within the country. And then we look at map 2, which is the Maori population. Yeah. And again, you can see on that, the graphic, you've got percentage of Maori ethnicity, areas that were less than 10%, 10 to 20% of the population of Maori, and greater than or equal to 20% were Maori as well. And so that graphic down the bottom talks about low accessibility and high proportion of Maori. In essence,
not you. No.
In essence, what it's showing is, can we turn actually the lights off? Is that possible? Just so we can get a better colouring. There you go. That, what would you call that colour? Mauve? Darker, purpley, grey colour?
This one is, this colour is high.
The what?
This color is the dark blue, I think.
Is it? Okay.
Yeah, kind of like shaded.
Yeah, that's right.
But this is the region that he's want to be.
Yeah, that's showing that's showing high proportion of Maori population and low accessibility of physiotherapy services. So the central North Island, you see that. East Coast, which is, see the tip pointing out this way, that's the East Coast, Gisborne, Hawke's Bay, high Maori population, low accessibility physiotherapy services. Northland up the very top, and the Coromandel, which is part of next to Auckland, Eastern Christchurch, parts of the city of Eastern Christchurch, which is close to the ocean, high proportion of Maori, poor accessibility, and Riverton in deep south, the South Island. So you're looking at disparity of accessibility for physiotherapy services.
And this time we use 3x3 classes, like low, medium, high.
That's right.
So instead of the above and below the mean values.
Sure.
And the socio-demographic factors as well.
Okay, so New Zealand's deprivation index scores from 1 to 10. 1 is low deprivation, 10 is high deprivation. And deprivation is a number of factors. There's about 8 or 9 factors in the deprivation index, from number of people in the house, low income, education levels, mold in the house, for argument's sake, heating. There's a whole bunch of factors that are factored into the census data to create New Zealand's deprivation index. Canada has a similar one. So in essence, the same colouring occurs. That same blue colouring is indicating high levels of deprivation and low accessibility for physiotherapy services. And in essence, if you go back to the previous slide, there's a very close correlation between that and the indigenous populations of New Zealand. Okay? So there exists from that mapping, as an example, there's a lot more to talk about from it, but there exists from that mapping areas of physiotherapy workforce shortage and potential oversupply. And overall, we don't think there's not too, what's the word for it? New Zealand doesn't have too little a number of physiotherapists. They have a very good number of physiotherapists. It's just the funding model tends to push the physiotherapists to where the people have money. And I don't blame them. But so this sort of information is related to policy-making decision. And this has been forwarded on. The New Zealand government have these copies of these reports. So in essence, where the health need is greatest for those areas of the population where they require it, the accessibility, at least for physiotherapy services and other health professionals as well, is low accessibility and for that higher proportion. And obviously overall maldistribution is more of the issue than there is for a shortage of physiotherapists. Now, we don't blame the physiotherapists, because I was one of those ones in New Zealand working where people can afford to pay me. That's a funding model for that healthcare delivery. So the public health model in New Zealand has decayed quite substantially, what the government is prepared to put into public health. And so these papers that we published on this have both been in spatial epidemiology and health policy journals. And so they've been presented to the New Zealand government and different New Zealand conferences as well. Now, there may be some other reasons why Maori tend not to access some of the physiotherapy services close by. They could be aspatial factors. Lack of cultural sensitivity by some physiotherapists, some different healthcare providers could be a factor. We don't know. But it is possible in these regions, these geographic regions, where we have high levels of accessibility and poorer healthcare, it is possible to then undertake qualitative studies in those regions to interview the people and ask why that might be and see if there's any thematic, I can't think of a better word, relationship between quantitative data and qualitative data as to why this would be. And that research is being done at the moment by Miranda in New Zealand at the moment as part of the project that she's doing. So we need better quality data, particularly in those aspatial areas. It's the first time it's been done. So, and then we also have, so the maps are very interactive and they can be built in such a way using ArcGIS that they are constantly in an updated format. And so you can access these maps online and in essence, you'll see they all spring up. And this is where Tayyab and Miranda created their maps and imported them into the slideshows and the manuscripts.
These are the locations we use.
Yeah.
And then they have like some details of those information. We have the number of practitioners working there. We have the address, and then some information we hide it. And then we have those pre-classified images, like access codes are there. Then we have cross-staff classification with the access to the geographic classification of health for the rurality. There's a deprivation index. And then we have those things. So we have those interactive areas, and then we can get the information. Just want to be like starting some idea of how this information can be moved from the static to the dynamic situation, where we can have more flexible parameters. Like sometimes people don't agree the buffer zones we decided, catchment area. So they have their own inputs if they want to be decided and see how they will see those accessibility in their own point of view.
So when you see the borders there, see where the word New Zealand is, you can see there's go back to the previous one, previous image, whatever that was. I am fine. Just anyway, take anyone where there's different colours, where the different colours meet. That doesn't mean it's point blank. You've got that level of accessibility, and your neighbour 200 metres down the road has less accessibility. Obviously, it merges together, it smudges together, but it's kind of hard to map a smudge. So it basically allows us to create the differentiation.
Okay.
So, Tayyab.
Yeah. So
first, one last thing. All my understanding that I've been trying to explain to you, and Tayyab has clarified a number of things as well, is from me working from him and him teaching me. Okay. And some of the stuff still goes. Occasionally I look at him, but it's going to go over my head. This guy is a specialist in geospatial mapping. He's one of the few people here at the University of Saskatchewan. And he's got a tremendous number of ideas. The input I put into it, and what Brendan's put into it as well, is our clinical experience and our clinical issues that have come up, that we're interested in exploring why these things are actually occurring. And the fact we had Tayyab on board, it could say, well, given these potential geographic circumstances relative to healthcare delivery or inequity of access, how could we potentially map this? And Tayyab would go, aha. So that's his speciality. So let him talk now.
Okay, thank you very much. So I will give you a brief background and moving away from the slide for a few minutes. So last time I came here, maybe in 2010 or 11, I shared some of my PhD work. And then after that, my journey was very interesting, and moving forward with a postdoc with Dr. Steve, and then moved to the London, Ontario, where I worked with Dr. Jason Gilliland. And we worked in a HEAL lab. It's very interesting, and there are different ideas, especially on the children's health. And then I run an experiment on hearing aid. So one of the company want to know where the hearing aid is not working or performing like better, and people like to switch off. So they need to understand the environment where those hearing aids are not working perfectly. So we have a 80 hours experiment wearing the hearing aid, moving around a different part of the city, bus, and the front seat, back seat, biking, running, indoor, outdoor. So we try to create the scenario, and then data was every second, coupled with the GPS, with the Lena device and voice and number of things we are moving around, and then we get the data. So then we categorize and then propose where that device auto switch is not performing well, and people feel like they have to switch off that hearing device because of the background noise and those kind of things. So I was involved in those kind of research in there, and then I moved to the Fiji Islands. I got 1 year teaching position there in the University of South Pacific. So it's a very interesting place, and I worked with undergrad students. We did a capstone project where we did almost 35 research projects independently. So I was in like swamp with the students' research, staying there late night in the office and in front of the South Pacific Sea. So it was a wonderful year. I have enjoyed that life over there. And then I came back. But while I was coming back, UNICEF raised a consultancy. They want to know how to enhance the immunization coverage in urban poor areas. So that's one of the issues, the Melinda Gates and the UNICEF and other stakeholders working together. and try to figure out. They had did a number of attempts or interventions, but none of them working. So let's try how GIS can help us. So there is a consultancy about 90 days, and I was shortlisted while I was in Fiji. So I was working on that project. So what we're trying to do is across the globe, all the slum areas, high population density, like in Brazil, India, Bangladesh, Pakistan, all those countries which have a large slum areas, high density population areas, how they need to be enhanced their regular immunization coverage. So I developed a framework for the UNICEF and then proposed the idea how GIS can enhance, that can play a role to enhance immunization coverage just before the COVID. So then that's important for us that people realize that this kind of immunization coverage is important because they were framing these urban areas. These pockets are very dangerous as compared to the rural areas. So I have opportunity to work with the UNICEF headquarters. And before that, before my PhD, I was in Pakistan. I'm working with different healthcare projects. So working with the MPH students and on their research project and national level projects and out of school children. So this is my background. So why I'm giving you the overview, because after going through all this experience and experiments with seniors, I come up with some ideas. So what we are doing on the university is the GIS Day. First, just for the information, every year in November, basically in the library, main library opposite to the Starbucks. So that area we have one day hold, and we ask everybody on campus or even in the Saskatchewan to come and present their work where you have some GIS. So we have the city of Saskatoon, highways, water security agency, and all those peoples like they normally come and attend. So we have some get together, have a computer, people showing their projects and moving around into that place. So that's activities going on. If you want to see what's happening on the GIS, that will be great. And last year we have some participation from the health sciences as well. So I have a wish list. So all this background, I have two proposals or maybe ideas which I'm working and I would just like to share with you quickly. So one is need a big project. Problem is like we talking about the individual, what is called the healthcare accessibility or their analysis. What about the integrated overall eco health systems? So this idea is if we want to be linking our different things and making more interactive dashboard or decision-making tool where we can do all those things. If you want to merge with the like a family physician, with the physio, with the OT, so you can have all the healthcare provider, you can click, define the parameter, you can define whether population, you will get all those maps and analysis on while you're interacting with that. So that's the first proposal is developing this kind of app. Second thing is developing a full course for where we can apply the GIS, because I know we have some biostatistic courses, they have like increasing the proportion of the geospatial, but they have no independent course where like health sciences students are normally have a chance to work on a GIS. So I'm proposing two things, one building a app, and the second one is having a full proposed course, which I wish, that's why I'm saying wish list. So I want to do these kind of things. I just want to share with you. So the first idea is basically where we need a screen, computer, online. We have like College of, Family Physician, College of Physician and Surgeons data, registry data, physios registries, all those healthcare providers, they have their own registry, they regularly maintain the data. So if we have a chance to link their live registry to online, so whenever we have somebody moving their location, adding and removing, so we have update data. We don't need to have a static information. That's the first scenario. Second thing is we have all the AI-based or advanced computer programming where we can put all the programming where we can make this one more interactive. So people can apply different methods, they can do different unit of analysis. Sometimes you want to be dissemination area, dissemination blocks. You want to do the analysis by the health networks. You want to do by the regional municipalities. So all the possibilities there. So you want to choose the things and click the button and you will get your results. So those kind of things will be can be taken to the scenario building. So you want to see in next 5 years, if the doctors are retiring, how many people are retired, where they are working, how the access will be impacted when the people are moved for the system, how we need to be like adjusting those kind of things. Full-time equivalent. We normally accessibility is head count. So we need to be see how many multiple locations people are working, how we want to be doing. So we need all possible information to improve these measures, and then we have more better planning and decision making in that case. So this app is a kind of like a idea how these different pieces will be worked together. So I want to be like heading to that way. Now I'm thinking to go more formal approach, and if we demonstrate that kind of things in a formal way. So there will be different things we can build the simulations, what if scenarios are out there, policy optimization, these kind of features we can keep adding it once we are having a basic integrated together. And then we can, I already talked about the full-time equivalent, unit of analysis, we can use those kind of things. Then we have a geocoding, those we can automatically locate based on the address. We don't need the actual coordinate, we can find a mechanism to do that. And then we have different road network distance, radial distance, distance decay. There are different methods for the calculate the distance. We can apply and give the option in the app. People can choose it based on their logic. Some areas people think the road is not there, so they want to see the radial distance. Sometimes they want to be using some other proxy Manhattan or a Euclidean distance, so they will use different choices of that to calculate the distance. Those options will be available in the app. You can pick and choose, and then you can track it. So the time series is also there, retirement scenarios, and then finally is you have integrated healthcare. So all the professions could be there. You can make the combination. How you think healthcare could be provided like in case of the farmer's injury. Like, so the farmer's injury is starting with the contacting family physician, refer go to the scanning, then go to the physio, or depending on the OT when they want to go back to the work. So all those healthcare need in that proximity. If they are missing, that means their healthcare will be a factor. So those kind of things, if you want to see, they have a complete solution for a particular kind of situation or injuries. So how those accessibility is available within their proximity. So those kind of scenarios you can build, like depending on who is working and see which professions need to be a combination and then how they work. So this is the one, and then the conference is coming in June. So we put this proposal over there and try to demonstrate something before in the conference. So one of the idea of this project will be to put different aspects, and we are combining in this area. We have family physician, emergency medical services, community pharmacies across rural, and then we have rehabilitation services. So we're trying to get all the data and putting them together and see how the combined accessibility will be in the rural municipality levels. Okay, so that's I think we are working on like on this idea. So there are a few examples of the paper which Dr. Steve mentioned. But what I'm trying to do is here, I'm trying to establish, like I worked with the different groups, network groups. Like one of them, you see, like I'm continuously working it. I have another group in Ontario working with them. I have some research going on back home Pakistan. Some people are working with Fiji. And then I have a national level and all those kind of things I'm doing. So I thought it's good to be start some teaching and using those examples as the case studies with the students can learn with the real data sets and hands-on on that kind of thing. So this is one of the projects, and this is a Ontario work which we did, one of the local network. And then I have some urban area levels work too. And what was the interesting work which I want to share? Let me know when the time is over. So this is quickly I want to share my research work with one of the companies called RAD-AID, which is providing the interventional radiology services to the low-income countries. They have over 33 countries and collaborate with more than 100 hospitals across them. And they try to reduce the maternal mortality and other screening related. So postpartum hemorrhage is one of the issue, and they want to see how the interventional radiology can be reach out. and then we're going to be prepared to hospitals by providing different kind of services. So then we work together in this idea, if we have one country, how to find more collaborative hospitals based on the need. So this paper is basically where we develop a methodology to establish those kind of things. We have different postpartum hemorrhage data, health severity, and then we combine those postpartum hemorrhage and health severity information together, different variables, put them together, and then finally we will come up with some ideas which hospital that company can further target to enhance their interventional radiology services to reduce the maternal mortality. So this is the way I'm using GIS in different scenarios. And these days I'm teaching a quantitative data analysis course in a teaching department where we are publishing paper as the outcome of the research of the course. So based on my experience, then I was proposing this course. This course will be a 3-credit course kind of things, and more outcomes. So the main thing is in this course is the 2 streams. I'm proposing the course to have 2 streams. One is the methodology, by all the methods, how to make the maps, classifications. But on the same side is why you need these maps. All these maps put together make it some full research paper. So that means one course will be talking 2 things simultaneously, but you will be exchanging the experience, and that's I'm doing over 25 years now. So most of the papers which I'm doing is basically based on working with the students and putting these 2 things together. And now I want to be proposing this idea can be replicated in health sciences, where we can do those kind of things together, where we have some ideas how GIS we will teach and how those paper writing will go. So they will be do more what is called as the theoretical knowledge of the GIS, because most of the healthcare professionals, they don't need it hands-on on the GIS, but they need to know how to apply it, how to interpret it, how to use in their different operations and management. So that means that course will also empower them to have understanding how to use the GIS in when they are working in an interdisciplinary team. So that is the idea which I was thinking to share with you. And I think that's all. They have a lot of other few ideas, but I think we are already over the time. Yeah.
Well, one last point that Tayyab brought up. All the research that we've done it by head counts. So if it says there's a physician somewhere in Alberta practicing in this district, and it's Dr. Dosman, for argument's sake, and say it's you practicing in this community, there's very little in the databases that are accessible that tells us that you were part-time, full-time, or you work 3 days here and 2 days there. So what we've got, we've got good numbers, 6,000 people and more, but there is some error factors built in. I think the error tends to wash itself out, because some people might work less hours, some people might work more hours. But in essence, what Tayyab brought it up in those slides was we need high quality data, and from the registration bodies, if that's possible, to actually indicate that someone's working part-time or they're in different locations from this situation to that situation.
Well, sorry, Angie.